Very good evening to all of you. I'm recording this presentation on YouTube after a long time. This is about regional anesthesia in a surgery, how to plan it and how to execute it. Giving regional anesthesia or giving a peripheral nerve block, it is not just like poking a needle and giving block and run away or complete the surgery, but it requires some planning and execution. We need to understand what to do preoperatively, what type of consent we need to take, how to go prepare the patient, how to go for ultrasound guided block, how to give PNS guided block, and how to do post-operative follow-up. So this is the entire process. This is not just giving a block. So if we learn it, we can give a better patient satisfaction, and for us also we can learn from our mistakes, and we can learn how we can give post-operative analgesia and prolonged pain relief to the patient. So as I said, regional anesthesia is becoming more and more popular because safety and accuracy, because of various gadgets like ultrasound and PNS. And if we properly plan and execute, uh, uh, we can give very safe anesthesia to the patient, and patient satisfaction can be also very high. So first part comes is pre-op assessment. We should know what is the proposed surgery. Suppose patient is humerus fracture. There are many surgeries, like if a fracture is in the shaft, then patient may require lateral position, and they may do plating. If it is nailing, then again it can be done in a big chair position. If it is shoulder surgery, again it is in big chair position. We don't require lateral position. If it is again supracondylar fracture, then the patient require lateral position. So we have to know what is the surgery. Then next important part is medical history, whether patient has other medical illness, uh, like hypertension, diabetes, or any other medical illness. Suppose patient has diabetes, then patient might have neuropathy, and in such patient we have to be careful while giving blocks. So we should know about it. Then we have to look for any neurological deficit. Suppose patient has fractured humerus. Sometimes patient had preoperative radial palsy, or sometimes patient has brachial plexus injury. So we have to look at it and document it. Then only we can go for regional anesthesia. Otherwise, blame game will come to you only. We have to look for medication history, like suppose if we are planning deep block like lumbar plexus or sacral plexus block, and patient is on anticoagulant, it is contraindicated. So we have to look for the medication history, and we have to look for any allergy to the patient. This is very nice consent form designed by Academy of Regional Anesthesia. I will show a bigger image or a better image of it. Here you can see this is informed consent designed by Academy of Regional Anesthesia, where there are separate consent for general anesthesia, spinal anesthesia, nerve block, and it is explained what is the exact procedure, and then they have explained about if there is any neurological deficit preoperatively, sensory or motor, other medical condition, AS status. Then there is a anesthetist declaration, and this is patient declaration. So this is mandatory. We should take an informed consent of the patient, so that patient can know the details of the surgery and anesthesia, and then patient can take a call. Some patients are not very willing for regional anesthesia, and they want general anesthesia. Then we can plan either general anesthesia along with regional anesthesia, or general anesthesia alone. Immediate pre-op planning is also important. Patient comes to the pre-operative area or operation theater. At that time, we need to discuss the plan of surgery and incision with the surgeon, because according to incision, sometimes block differs. Like suppose a block is on the lateral side of the shoulder, then we need to block superficial cervical plexus along with brachial plexus. If incision is medially, then we need to block T2, that is intercostal nerve. For that we require just local infiltration, but we need to do it for complete anesthesia and analgesia. So we have to think of dermatome, myotome and osteotome involved, and according to we have to plan the nerve block. And we should always be ready for plan B or general anesthesia for any block procedure. So even if you give if you are an expert, sometimes block fails and you have to go for general anesthesia, and sometimes there are because of some complication we have to go for general anesthesia. This is again very good pre-procedure checklist prepared by AORA. It says that we have to first confirm then perform. So we have to stop before we glop. We have to check patient's name, age, sex and hospital ID, whether we are giving block to right patient or not. Then we have to check about procedure like diagnosis, surgery and intervention, whether it is emergency or relative. What block we are planning and block site should be marked. Then documentation should be checked, like there is signed informed consent is taken or not, complete PSC is done or not, patient is allergic to LA or any other drug, and patient is adequately fasted or not. Then we have to check the equipment, like emergency drugs are loaded and available or not. Last, local anesthetic system toolkit should be ready all the time. Intralipid should be available whenever we are performing the block. Anesthesia machine should be checked for plan B. Airway and resuscitation equipment should be available. It is must. And we have to start monitoring like SpO2, ECG, NIBP in all the block patients. Pre-block check, we have to take IV line. We should check whether we are going landmark guided or we are doing with USCR PNS. Then we have to check the functioning of the machine, and strict aseptic precaution should be it should be a rule. If there is any specific consideration like use of antiplatelet drug, anticoagulant drug, we have to check. Last date dose of the drug administered we should check. Condition affecting coagulation status like sepsis, liver dysfunction should be checked. Coagulation profile should be normal, and there should be no pre-existing neurological deficit. If we find all this proper, then we should go for the block. If it is ultrasound guided block, we have to switch on the machine. We have to select the probe. There are two types of probe we will see in the next slides. We have to select preset and examination. We have to select the depth, and we should do scout scanning. So there are two types of probe. First is curvilinear probe. It has got better penetration. It is good for deeper structure, but it has got lower resolution. So it is good for abdominal imaging and for deeper blocks like sciatic nerve block or lumbar plexus block or QL block. This is good probe. But if you want to give other blocks like upper limb blocks or femoral nerve block, then linear probe is better because it has got lesser penetration. It is good for blocks that those are 4 to 5 centimeter deep, but it has got very good resolution, so you can identify structures in a better way. So it is good for nerve blocks, or it is good for central venous cannulation or lung ultrasound. We have to check for the aspect marker so that we can see which side of the screen is on which side. So here you can see this is the aspect marker, and there is a green dot correspond to it. So you can confirm whether it is on the right, your needle will come from this side or this side by putting the aspect marker. If you don't know how to check, you can just apply some jelly on the probe, and you can check where there is movement. So here you can see on the left side of the screen there is movement. So you can keep that part either on the medial side or lateral side, and you can confirm it. How to select the probe? This is very important. Where is the area of interest? As I said, if it is deeper, then we have to select the curvilinear probe. It is superficial, then we can select the linear probe. And size of the patient is also important. Suppose this is the patient who is very obese, then even for tap block sometimes we required a curvilinear probe. So we have to select the probe according to the size of the patient. Knobology is very important. we have to look at the preset or examination in certain machine. Depth, we have to set the depth. We should know about gain, color Doppler, and pulse Doppler. So this is pre-fold, that is before pre-optimized mode. So suppose if we select the now block preset, we have to click on the preset or examination in other machine that is on site. Then we will find certain options like abdomen, obstruct neck, and SMP, that is small parts. When we select SMP, then what we will find is thyroid, breast, musculoskeletal nerve block. Then we have to select either nerve block or musculoskeletal block for facial pain block. So once we select that, we have to set the depth. Suppose block is superficial like supraclavicular block, then we have to select the depth like 3 centimeter. If it is deeper like popliteal, then we have to go for 4 to 5 centimeter depth. So we have to adjust the depth. Here you can see this is the supraclavicular area. You can see this is the artery. If it is if it is too deep, then we cannot see the structure properly, and if it is too superficial, we have reduced the depth here, but it is difficult to see beyond the artery, and this is the plexus. So we have to optimize the depth. Like at this level, this is optimum depth, where we can see the rib, we can see the pleura, we can see the vessel, we can see the plexus. So this is the optimum depth for the patient. So it varies from patient to patient, and we have to select it after putting the probe. And then next comes the gain. After putting the probe, sometimes picture might be too dark like this, or too bright like this. So we have to go for optimum image, where we can see where it is not too bright or too dark. So here again, this is too dark pictures. So if we increase the gain, it will become too brighter. So we have to go in between where we can see the structure properly. So even there is a auto gain mode. We can click on it, and it will go into the default mode. Color Doppler, this is very important to identify the vessel. Here in the machine you can see CF button, or in other machines there is color also. So we click it and we can find the color of the vessel. It is not like that artery are red and vein are blue. This is a subclavian, this is carotid artery, and this is the internal jugular vein. But here you can see vein is red and artery is blue. Depends on the flow of the blood. So if it is towards your probe, then it is red, and if it is away from the probe, then it is blue. So this is called Bard principle. Blue is away and red is towards. Here again you can see artery is blue and vein is red. But if you reverse the probe, that direction, it becomes red to blue and blue to red. So this is how you can do it. You can see it is converting blue to red and red to blue. Pulse wave Doppler, again it helps to identify the vessel. You have to click the knob, and what you will find is if you put the probe on this area, or that is artery, you will see the pulsatile waveform, and if it is on the vein, it is a squarish waveform. So you can confirm whether it is vessel is artery or vein. Now, how to do image acquisition and optimization? We should know the anatomy, and landmarks are very important. Even if we are going landmark ultrasound guided blocks, we should know the anatomy and landmarks. Anatomy, if I tell about anatomy, it is very nicely said that you see what you look for and you recognize what you know. So if you don't know, you will never recognize what is the structure. So you should read the anatomy, then only you know it. Knowing the landmarks, again, it is important. If you don't know the landmark, you will dig on the wrong side. Next important thing is ergonomics. You have to be comfortable while giving the block. It should be not like this, that you are looking, your probe is on the other side and you are looking on the other side. You should be comfortably sitting on the chair and giving the block, or else you can stand and give the block. You must be comfortable while giving the block. Here you can see I am sitting on a chair and giving supraclavicular block. uh, Along the probe or across the probe. This is a very nice study where they show two techniques, uh, where they kept the machine on the opposite side, and this is the across the probe and this is the along the probe. So if you go along the probe, needle visibility is better because you are looking at the needle, probe and machine all together. So needle visibility is better as compared to across the probe. So how it is seen, I will show in the this video. This is the along the probe where needle, machine and probe all are aligned, but this is across the probe. Here you can see my probe is like this and needle is going across. So needle visibility is poorer with this technique as compared to the along the probe technique. When you can not see the desired structure, apply part, that is pressure, alignment, rotation and tilt. So you can either rotate the probe or align the probe to the structure, or sometimes you have to tilt the probe, or sometimes you have to apply pressure to see the structure. Here you can see this is a obese patient where you cannot see anything here, but once you apply, this is for rectus shield, once you apply pressure you can see head is compressed and you can see the rectus muscle very nicely. Tilting and anisotropy important. This is median nerve scanning. Here you can see median nerve is seen, but when I tilt the probe it goes away. So tilting is very important to see the structures. Artifacts, there are certain artifacts which come in between when you are doing the ultrasound scanning. If your probe is not in the contact with the skin properly, and if you are not applied the gel, there will be dropout or contact artifacts. You cannot see anything if there is air in between the probe and your body surface. So you have to use proper jelly, and you have to properly contact the probe while doing scanning. Shadowing, below the bony structure there is a shadow, and there is an enhancement below the vascular structure. So there is a hypericosity below the vessel, which sometimes you take it as a nerve, but it is enhancement because of the vascular structure. This is bayonet artifact. This is basically because of propagation speed. When you inject the drug, this is particularly seen in the popliteal area. After injecting some drug, there is a difference between the propagation speed in this muscular area and this area. So it looks like a needle is bended. It is called bayonet effect or bayonet artifact. And reverberation artifact, it is very common, especially in the axillary block. You will see multiple needles. This is because of ultrasound beam hit the needle, go back, again hit the needle, go back. So it will create multiple shadows like the needle, and that is called reverberation artifact. Again, this is mirror image. Sometimes when there is a vessel above the bone, this is supraclavicular area, you will see a mirror artifact below the bone also, and it looks like the vessel. But if you change the angle of the probe, it will go away. Visualization of the needle, this is very important. It is difficult because ultrasound beam is 1 millimeter thin. So if it is in this beam, then only you can visualize the needle. But there are certain maneuvers with which you can visualize it in a better way. Suppose angle of the needle is more, then it is difficult to visualize, but if it is parallel, it is better visible. Why it happens? When you select the probe and needle and angle is more, so some of the waves go away from the probe, so needle is not properly visualized. But if it is parallel to the probe, all the reflected wave go back to the probe, and you can easily visualize the needle. You can use cornerstone needle with cornerstone reflector, that is ecogenic needles, and they are available in the market. Healing maneuver is also important, especially in blocks like tap block. You can press the probe on one side to make it parallel to the needle. Here you can see there is angle, but if you press the probe, it becomes parallel to the needle, and you can see the needle in a better way. Here this is healing maneuver. Initially probe was applied on the skin and needle is at angle, so it is difficult to visualize. But once you do healing maneuver, it is become easier to visualize the needles. Needling technique, there are two techniques. One is in plane technique, where you go parallel to the probe and you can try to visualize entire needle shaft, and other is the out of plane technique, where a dot is visible but you cannot see entire needle shaft. So once your tip is under vision, you can see the start seeing the needle, but shaft is also looking like the needle tip also. So you have to continuously move probe as you advance the needle to see the needle tip, and you can see the where your needle is going, or you do use hydrolocation. So in in-plane technique, look at the hand, slide probe and do Healing maneuver to visualize the needle. And with out-of-plane technique, slide the probe, tilt the probe or adjust the needle. So we have to keep sliding the probe as you advance the needle while doing out of the plane, or we have to tilt the probe to see the needle tip, to see where your needle tip. You can use hydrolocation. You can inject 1 or 2 ml of saline to see where your needle tip is. So here you can see if a needle is exactly under the ultrasound beam, you can see the needle, entire needle. But if it is alignment is not proper, then entire needle is not seen. Here you can see this is the out of plane technique, where you can see a dot only, and as you advance the needle, shaft will also look like the needle tipped. So here you can see this is the maneuver. As you advance the needle, you have to advance the probe to see the needle tip. So when you prepare the to summarize the thing, when you are preparing for the scan, you have to look for the supply like drugs, needle, and all those things. You have to take a comfortable position. Ambience should not be too dark or too light. We should check name of the procedure. We have to nominate the transducer. We have to take proper aseptic precaution, that is infection control. We have to note orientation on the screen, which side is the orientation marker, and we have to gain and depth setting. So we have to start with scanning, that is supply, comfortable position, ambience, name of procedure, nominate transducer, infection control, note orientation on the screen, and gain and depth setting. Key for success: understand the surgery and anatomy. Monitoring should be done all the time. Stop before you block is important. Set up the machine properly. Pre-procedure scan and find the best image. Holding the transducer is also very important. Keep needle parallel to the transducer to see it all the time. Bevel should be towards the transducer. If you keep it towards transducer, visibility is better. Advance only when you see the needle tip, and there should be no air in between probe and the skin. Echogenic needle is always better. If you don't see, do hydrolocation. Inject first to deep target so that the superficial target becomes more superficial. If you go for a superficial target first, then deeper target, go more deeper. So it is difficult to identify the structure. Pass through fascia slowly, awaiting a pop or sudden release. Reoptimize image of needle tip after passing through fascia, because you have to apply the pressure while passing through fascia. So sometimes sometimes image get disturbed, so you have to reoptimize the thing. Inject LA solution in small L cuts. Never inject all the drug at a time. Go slowly to avoid any complication. Observe for pain or high pressure during injection. Always inject yourself. Don't ask your assistant to inject to check the high pressure, or you can use some devices. Make certain that spread of the fluid is observed at needle tip during injection, so that you can confirm that it is not intravascular or you are not damaging other structure. Aspirate between injection, that is a basic thing, and you should be follow it always. For solitary nerves at extremity, seek for the donut or halo around the nerve for complete block. Learn hand-eye coordination, that is important. Practice with blue phantom. Move either needle or transducer at a time. Don't move both at a time. Don't inject if you can't see the needle tip. That is very important. So if you follow all this, you can give successfully the ultrasound guided blocks. Now what to do with PNS guided block? There is again guideline by Academy of Regional Anesthesia. It tells we have to stop before block, confirm side of the block, look for availability of interlopid. These are the common things. Then we have to check the PNS machine properly whether it is working or not. Uh, we should confirm that the patient is not under general anesthesia and the patient has not received the neuromuscular blocking agent, otherwise it is not possible to use PNS. And presence of neuroaxial anesthesia doesn't affect the stimulation. So if patient has taken spinal, you can give peripheral nerve blocks. For block procedure, always use insulated needle. For superficial block, you can use 50 needle, and for deeper block, 100 For superficial block, set PNS to 1 milliampere, then, and for deeper block, start with 1.5 milliampere intensity. Set PNS in 0.2 millisecond current duration. Set frequency to 2 Hz. End motor response between 0.3 to 0.5 milliamp considered safe and ideal, except lumbar block where below 0.5 milliamp is unsafe. So for lumbar plexus block, 0.5 is the limit. Aspirate before injection for LA at 5 ml cut is must. Always try to inject yourself and shouldn't inject again high resistance. Use of injection pressure monitoring device is advisable if it is available. Keep testing the patient while giving LA to detect signs of immediate LA toxicity. Injection of sodium chloride for hydrodissection will abolish muscle twitches. However, with dextrose solution, twitches will not disappear. This is called Raj test. So when you want to put a catheter, always use dextrose solution rather than sodium chloride solution. These are the desirable end responses for various block like interscalene block. If there should be contraction of pec major or deltoid or triceps or bicep. For supraclavicular finger or wrist twitches. For axillary nerves, different twitches for different nerves. Femoral nerve block, we look for the dancing patella. So these are the various responses. We should know it, and we should look for it. After procedure, documentation should be done for procedure. We should write down time, needle type, size, disappearance of EMR at what current, setting of the PNS before injection of LA, injection resistant or ease of injection, tingling or numbness during or after injection, and vitals should be noted. Assessment of the dermatome, myotome, and osteosome should be done after 30 minutes. Like suppose if you are doing sciatic now, it will take 30 minutes for complete effect. So we should do assessment after 30 minutes only. If all are blocked, then only we can proceed for the incision of the surgery. So don't do it in a hurry. Use proper sedation techniques to make the patient calm. We have to use optimum multimodal anesthesia technique and sedation. Blocks will act for 6 hour, 8 hour, 10 hour, or 20 hour, but we should start multimodal anesthesia like paracetamol, NSAIDs, or tramadol, or other drugs for postoperative anesthesia, so that patient has no rebound pain. We have to monitor patient during entire procedure. Monitoring is must. We should use ECG and IBP, SpO2, and pulse monitoring in all block procedure. And we should always be prepared for the general anesthesia. This is very important. And last part is post-op management, that is management of pain with different MMA techniques. We have to design our own techniques, and we should use it so that patient's post-operative period should remain pain-free. Never miss post-op visit on next day. Document neurological recovery. Sometimes after 24 hours, patient has no neurological recovery, then we should think of nerve injury and other things. In case of prolonged effect, take necessary action. We have to involve other specialty like neurophysicians if patient has prolonged motor deficit after blocks. And we have to look for other post-op complication and documentation. This is very important. If we detect the complication, if we document it, if we treat it, we are safe. But if we miss it and patient has some complication, then it is disastrous. So we have to do post-operative visit and all these things. So to conclude the things, regional anesthesia is not just giving block and go away. It requires proper planning and execution for a successful regional anesthetic block and for a satisfied patient. Patient will be very happy if patient remain pain-free during surgery and post-operative period. You have to think of other modalities of multimodal anesthesia for complete package. If you have given block and if you think that now patient is completely pain free and the patient will not have any pain after surgery, then you are at fault. You have to use other methods for complete pain relief. So this is all about how to use regional anesthesia technique in surgery. Thank you very much. I hope you enjoyed the presentation.